Today we will consider the importance of sclerosis, fibrosis and cirrhosis using the examples of pancreasclerosis and cirrhosis of the liver. Chronic pancreatitis is characterized by fibro-inflammatory changes to the pancreatic tissue. It may develop in association with alcohol abuse, smoking, gene mutations, autoimmune syndromes, metabolic disturbances, environmental conditions, and anatomical abnormalities. Chronic pancreatitis is a rare disease that affects from 7 to 10 persons per 100,000 per year. The largest numbers of patients are found in industrialized countries, and approximately 80% of them are alcoholics. Alcoholic pancreatitis and most of other etiological forms are present in adulthood. Exceptions are hereditary pancreatitis, which may already occur in childhood, and tropical pancreatitis, which often affects adolescents. The pathology of chronic pancreatitis was formerly considered to be uniform, but currently it is more and more seen as varying according to the etiology of the disease. The rather vague term chronic sclerosing pancreatitis should and can be replaced by etiologically derived terms such as alcoholic chronic pancreatitis, hereditary pancreatitis, autoimmune pancreatitis, paraduodenal pancreatitis, or groove pancreatitis, or cystic dystrophy of heterotopic pancreas, and obstructive chronic pancreatitis. Some morphological features, such as the composition of the inflammatory infiltrate and the fibrosis pattern, may be a clue to a certain etiology. For instance, the development of fibrosis, whether it is more inter- or perilobular or intralobular, depends very much on the site of the initial injury in the pancreas, and this is strongly related to the actin etiological factor. Apart from these more general mechanisms, chronic pancreatitis is very much an individualized disease, although driven by the same etiology. It may progress rapidly in one patient while developing slowly and being clinically insignificant in another patient. Since 1963, several classifications of chronic pancreatitis have been introduced. These classifications were mainly concerned with the distinction between acute and chronic pancreatitis. Moreover, they focused primarily on alcohol-induced chronic pancreatitis and only marginally considered the non-alcoholic types. Finally, none of the classifications correlated the etiology with morphological, functional, and clinical features. Hence, there is still a need for a classification that includes all currently available criteria for the characterization of the various types of chronic pancreatitis. On the slide, you can see a classification proposal based on the etiology of the disease. The patients are usually, in cases of alcoholic chronic pancreatitis, the patients are usually young or middle-aged men, 25 to 50 years, who develop the disease after approximately 10 years of alcohol abuse. The younger the patients are when they begin their abuse, the shorter the time required for chronic pancreatitis to develop. However, of the total number of heavy drinkers, only 10% suffer from chronic pancreatitis. At the early stage of alcoholic chronic pancreatitis, patients experience relapsing episodes of acute pancreatitis, particularly with severe recurrent pain. In its advanced stage, alcoholic chronic pancreatitis is characterized by pain, stearia, and diabetes. In addition, patients with this disease have an increased risk of developing a pancreatic carcinoma later in life, particularly if they have a hereditary form of chronic pancreatitis that starts very early in life. In the early stages of alcoholic chronic pancreatitis, the gland shows unevenly distributed fibrosis. The involved parts of the gland appear indurated and may be enlarged, showing coarse lobulation and or nodular scarring on the card surface. On the picture you see pancreatic head resection specimen from a patient with chronic pancreatitis of 5 years duration, showing scarring of the parenchyma, shown by the red arrow, and calculi, shown by the black arrow. Only the ducts that are embedded in fibrotic tissue show irregularities and occasionally may contain calculi or calcified protein plugs. In 30 to 50% of the cases, there may be pseudocysts, which are usually extrapancreatic and commonly occur in the region around the body and tail of the pancreas. In addition, there are foci of recent necrosis in the vicinity of scars and pseudocysts. In advanced chronic pancreatitis, the pancreas has a firm consistency and usually shows an irregular contour without the normal lobulation. The fibrosis may diffusely affect the entire gland, but occasionally it is still unevenly distributed, leaving the lobular pattern of the organ preserved in some areas. On the picture you see advanced stage characterized by the calculi in the pancreatic duct, shown by the red arrow, and diffused by patchy fibrosis of the parenchyma, shown by black arrows. The severity of the duct changes depends on the extent of the surrounding fibrosis. Therefore, the main duct may be only focally obstructed and or dilated or diffusely involved with irregular dilatation and distortion. Usually, in 80% of cases, the main duct contains calculi. The calculi, which consist of calcium carbonate, vary in size from less than 1 mm to more than 1 cm in diameter. They may be impacted in the ducts and therefore difficult to remove. In some cases, they may disappear during the course of the disease. Fibrosis in the pancreas head may cause a tapering stenosis of the common bile duct. On the picture you see pancreatic head resection specimen showing intense scarring of the parenchyma, shown by red arrows, causing a tapering stenosis of the common bile duct, shown by the black arrow. Thick-walled pseudocysts, usually attached to the pancreas, are present in 1/4 to 1/2 of the cases. They vary in size from 3 to 10 centimeters in diameter and are filled with necrotic material and or turbid fluid-rich enzymes. The pseudocysts may be connected with the duct system. Occasionally, they may erode the major portal veins, causing thrombosis, bleeding, and rarely disseminated fat necrosis with subcutaneous nodular pancreatitis, polyarthritis, and necrotic bone marrow lesions. Histological examination of the early stages of the disease reveals interlobular or perilobular cell-rich fibrosis. On the left picture you see acinar lobule, shown by the stars, with interlobular and perilobular fibrosis shown by yellow arrows. The involved intralobular ducts are distorted and may contain eosinophilic secretions, the so-called protein plugs. In addition, the epithelium may display metaplastic or hyperplastic changes. Moderate number of lymphocytes, plasma cells, and macrophages are present, either in local accumulation or scattered diffusely throughout the fibrous tissue. In the perilobular tissue, there may be foci of resolving fat necrosis, and on the right picture you see pancreatic parenchyma with resolving fat necrosis shown by black arrow in the perilobular tissue. So there may be foci of resolving fat necrosis with large numbers of vacuolated macrophages or foam cells in the immediate vicinity and cell-rich fibrosis in the surrounding area. The necrotic foci are often in the vicinity of large pseudocysts which lie outside the pancreatic parenchyma. In advanced chronic pancreatitis, fibrosis affects most of the parenchyma, but still to varying degrees. While in some areas there is only perilobular fibrosis, as on the left picture shown by yellow stars, others show diffuse intralobular fibrosis, as on the left picture shown by white arrow with sparse lymphocytic infiltrates. Perilobular fibrosis causes duct distortions and dilatations. The picture in the middle shows distorted ducts with protein plug shown by red arrows, with occasional formation of a retention cyst. The lumens of these interlobular ducts are often filled with protein plugs and calculi. The duct epithelium is either atrophic or completely replaced by polymorphocellular inflammatory tissue. In areas with intralobular fibrosis, the elements that remain are islets, thick-walled blood vessels, prominent nerves, and remnants of acinar cells, which may be atrophic, undergo apoptosis, or form the so-called tubular complexes. The nerves have been found to be damaged by the inflammatory process. The islets may form large adenomatoid aggregates in the fibrotic tissue, and on the right picture they are shown by stars, and sometimes they are in close contact with ductules shown by the black arrow that show islet cell nerve formation. The number of beta cells in these islets was found to be slightly reduced. Immunohistological studies revealed that the duct epithelium commonly expresses human leukocyte antigen complex and cytokines such as transforming growth factors alpha and beta and fibroblast growth factor. Transforming growth factors beta 1 and platelet-derived growth factor were also found in fibroblasts, macrophages, and platelets. Myofibroblasts, which were recently named pancreatic stellate cells, are identified by their positivity for smooth muscle actin and desmin, shown on the picture by red arrows. The lymphocytic infiltrate consists largely of T lymphocytes. The remaining acinar cells stain brightly for pancreatic enzymes and pancreatic stone protein. The nerves that appear enlarged express particularly calcitonin gene-related peptide and substance P. Both the endothelial cells and endocrine beta and alpha cells show strong endothelin-1 expression in chronic pancreatitis. Persistent stenosis of the bile duct develops in approximately 10% of the cases, while duodenal stenosis in about 3%. These complications are either due to intensive scarring or to the development of the pseudocysts in the head of the pancreas. Pseudocysts are found in 30 to 50% of patients with chronic pancreatitis. They are usually thick-walled. The wall consists of granulation and fibrous tissue and lacks an epithelial lining. Identical features are observed in pseudocysts associated with acute pancreatitis. Pseudocysts are usually connected with the duct system and therefore rich in pancreatic enzymes. They may expand and exert pressure on the surrounding organs. Further complications are fistulas in the pleura, leakage of pancreatic juice into the peritoneal cavity, or hemorrhages from eroded vessels into the cysts and the pancreatic duct system. Some pancreatic duct stents used for the treatment of chronic pancreatitis have been found to cause changes in the duct system that may aggravate the chronic pancreatitis they are treating. With increasing fibrosis of the pancreas, the patients develop exocrine and endocrine insufficiency. Exocrine insufficiency results in maldigestion, which usually becomes obvious after 80 to 90% of the parenchyma has been replaced by fibrosis. The incidence of diabetes increases with the duration and severity of chronic pancreatitis. The question whether chronic pancreatitis involves an increased risk of the development of pancreatic ductal carcinoma has been a controversial issue for years. It now appears that patients with chronic pancreatitis, particularly if they have the hereditary form, have a higher risk of developing pancreatic carcinoma than the normal population. It is interesting that KRAS mutations, which are very common in ductal adenocarcinoma, may also occur in the hyperplastic duct epithelium of the pancreas in patients with chronic pancreatitis, particularly with a duration of more than 3 years. In all westernized countries, alcohol is the most common cause of chronic pancreatitis. In addition, smoking seems to be an independent etiological factor. The reason why only 10% of alcoholics develop chronic pancreatitis is unclear. Presumably, there is an additional, potentially genetic factor in the development of alcoholic chronic pancreatitis that makes certain patients more susceptible to the disease than others. Recently, mutations of the cystic fibrosis transmembrane regulated gene, CFTR, have been implicated in the pathogenesis of chronic pancreatitis, and it has been suggested that the functional consequences of these mutations, including the impaired flow of secretion, could predispose their bearer to the development of chronic pancreatitis. Whether the alcoholic who remains free of chronic pancreatitis may develop some particular kind of diffuse fibrosis of the pancreas, distinct from that which can be seen in elderly patients without any known risk factors for chronic pancreatitis, has yet to be established. Several theories have been put forth to explain the pathogenesis of alcoholic chronic pancreatitis. The most popular hypothesis is that of Searles and co-authors, who suggested that chronic ethanol consumption increases the protein concentration in the pancreatic juice, with subsequent precipitation of plaque-forming secretions in the ducts, which later calcify. More recently, Searles' group identified a protein in pancreatic juice that prevented calcium CO3 precipitation and was therefore called lithostatin, formerly pancreatic stone protein. It is thought that abnormal secretion of lithostatin due to either an acquired or an inherited defect in its biosynthesis contributes to the calcification of protein plugs in the pancreatic ducts. The formation of stones leads in turn to duct obstruction and ulceration of duct epithelium, two mechanisms that cause acinar atrophy and fibrosis upstream of the obstruction as well as periductal inflammation. Although this hypothesis is attractive, it has been criticized for several reasons. First, the findings concerning altered lithostatin biosynthesis and function in chronic pancreatitis have not been universally confirmed. Second, the hypothesis only recognizes chronic pancreatitis as an alcohol-induced disease and neglects the fact that acute pancreatitis may also be caused by alcohol. Third, alcoholic acute and chronic pancreatitis have many features in common, such as clinical symptoms and the presence of pseudocysts. Fourth, in alcoholic acute pancreatitis, no pre-existent changes due to chronic pancreatitis have been found, whereas the pancreas of patients with chronic pancreatitis may show signs of acute pancreatitis, such as outer digestive tissue necrosis. Fifth, in its early stages, chronic pancreatitis lacks calcification. In recent years, the plaque hypothesis has been challenged by the necrosis-fibrosis sequence concept. This theory postulates that alcoholic chronic pancreatitis is initiated by relapsing severe acute pancreatitis. The resorption of large areas of fat necrosis and hemorrhagic necrosis, which are the main events in severe acute necrotizing pancreatitis, induce fibrosis, possibly through the action of growth factors such as transforming growth factor alpha and beta, shown on the picture. On this slide, you see the natural history of alcoholic pancreatitis. Mild acute pancreatitis is characterized by spotty peripancreatic fat necrosis, which is resolved without inducing significant fibrosis. Severe acute pancreatitis with large confluent areas of peripancreatic necrosis but little intrapancreatic involvement leads to an extrapancreatic pseudocyst. Relapse of severe acute pancreatitis with extensive extra and intrapancreatic foci of necrosis induces perilobular fibrosis and duct distortions. In addition, there may be extrapancreatic pseudocysts. Early-stage chronic pancreatitis evolve into end-stage chronic pancreatitis with severe duct changes, diffuse but still patchy fibrosis and calculi. Although the necrosis-fibrosis sequence nicely explains the perilobular fibrosis pattern, the patchy distribution of fibrosis and the late occurrence of calcifications in the pancreas of patients with alcoholic chronic pancreatitis, certain questions still need to be answered. First, it is difficult to reconcile the fact that the necrosis-fibrosis sequence also holds true for the primary painless chronic pancreatitis that may be observed in 5 to 10% of alcoholics. Second, biliary acute pancreatitis, which may occasionally be as severe as alcoholic pancreatitis, virtually never progresses to chronic pancreatitis. The fibrosis develops primarily in the perilobular space where fat necrosis and most of the hemorrhagic necrosis occur. Perilobular fibrosis in turn affects the structure of the interlobular ducts, gradually creating duct dilatations and strictures, shown on the picture. In these altered ducts, the flow of secretions is most likely impaired, a situation that may trigger the spontaneous precipitation of proteins with subsequent calcification. In addition, the impaired and eventually interrupted flow of pancreatic secretions leads to fibrotic replacement, of the acinar cells upstream from the occluded duct and finally results in intralobular fibrosis. A third hypothesis, called the toxic metabolic hypothesis, was put forth by Bordalo and co-authors and Noronha and co-authors. This hypothesis postulates that chronic alcohol consumption induces progressive acinar lipid deposition with acinar atrophy and intrapancreatic fibrosis by exerting direct toxic and metabolic effects on the acinar cells. Because the described pancreatic changes, particularly the fatty degeneration of acinar cells, have not been confirmed by others, the significance of this concept for the pathogenesis of alcoholic chronic pancreatitis seems to be minor. The fourth hypothesis, the oxidative stress hypothesis, postulates that oxidative stress in pancreatic acinar cells induced by excess free radicals causes a blockade of the intracellular pathway fusion of lysosomal and zymogenic compartments and membrane lipid oxidation. These events then lead to an inflammatory response. The hypothesis focuses on possible functional disturbances underlying acinar failure, but fails to explain the particular fibroinflammatory process that characterizes chronic pancreatitis. Hereditary pancreatitis usually starts already in childhood or adolescence. Clinically, it resembles alcoholic pancreatitis. It is very rare compared with alcoholic chronic pancreatitis and accounts for no more than 1 to 2% of all patients. It has recently been shown that the genetic alterations in hereditary chronic pancreatitis involve the cationic trypsinogen gene or the serine protease inhibitor casal type 1 gene. The third gene with mutations associated with chronic pancreatitis is the cystic fibrosis gene, cystic fibrosis transmembrane conductance regulator, CFTR. Mutations in the first two genes, PRSS1 and SPINK1, seem to trigger the autoactivation of trypsinogen in the pancreas, which in turn results in the early inappropriate activation of the other pancreatic enzymes with subsequent autodigestive necrosis and inflammation. The most important trypsinogen gene mutation, R122H and N21I, are gain-of-function mutations and have a disease penetrance of 80%. SPINK1 mutations are loss-of-function mutations and may result in elevated trypsin levels within the pancreas. So far, the role of the cystic fibrosis transmembrane conductance regulator CFTR mutations in the pathogenesis of chronic pancreatitis is unclear. We do not yet know where in the pancreas the premature activation of trypsin takes place. It may occur either already in the acinar cells or only in the duct system. In patients with hereditary chronic pancreatitis can found advanced chronic pancreatitis with massively dilated ducts containing protein plugs shown by the star and calculi. On the picture you see hereditary chronic pancreatitis, massively dilated duct shown by the black arrow, surrounded by fibrotic tissue that extends into the perilobular region shown by the stars. The fibrosis showed a periductal and intralobular pattern. The ductal necrosis is typical in some of the medium-sized interlobular ducts that destroyed the duct epithelium and led to an intense chronic inflammatory reaction in the periductal area. On the picture you see interlobular duct shown by the arrow with periductal inflammation and interlobular fibrosis shown by the stars. This finding suggests that the autodigestive process in hereditary chronic pancreatitis may occur in the duct lumen, resulting initially in necrosis of the duct lining cells and subsequently affecting the surrounding interstitial tissue. So the relapse in autodigestive necrosis occurs particularly in the large ducts. It may gradually induce scarring of the surrounding interstitial tissue with subsequent dilatation of the involved duct segments. In addition, there may also be autodigestive necrotic events in the interlobular areas next to ducts that initiate and promote interlobular fibrosis. Large areas of necrosis may be transformed into a pseudocyst. The calculi can be found in the dilated ducts are probably a result of the obstructed flow of pancreatic secretions, which promotes the precipitation of calcium from the pancreatic juice. In recent years, autoimmune pancreatitis has been established as a special type of chronic pancreatitis. The first reports describing such pancreatitis date back more than 50 years. Ball and Coffers described patients with pancreatitis in conjunction with ulcerative colitis. In 1961, Sarle and Coffers reported a case of sclerosing pancreatitis with hypergamma-globulinemia. The term autoimmune pancreatitis was coined in the 1990s. Meanwhile, a number of reports of individual cases or small series of cases using other terms such as lymphoplasmacytic sclerosing pancreatitis with cholangitis, non-alcoholic duct-destructive chronic pancreatitis, and chronic sclerosing pancreatitis have been published. Most patients suffering from autoimmune pancreatitis are 40 to 60 years old. The mean age is 56. It appears that the patients who have a more pronounced neutrophilic inflammatory cell infiltrate, known as granulocytic epithelial lesions, are usually in their mid-40s. The gender ratio also varies with the histological pattern. The younger group with neutrophilic inflammation contains equal numbers of men and women, whereas the older group lacking neutrophils is predominantly male. Clinical symptoms include abdominal pain, anorexia, and jaundice. Jaundice is caused by direct involvement of the bile duct by the fibroinflammatory process and occurs in about 75 to 80% of the patients. In approximately 20% of the patients, there are associated diseases that are thought to be of autoimmune origin: Sjogren's syndrome, idiopathic retroperitoneal fibrosis, lymphocytic thyroiditis, and ulcerative colitis. Some of these conditions appear to be more common in one of the two clinical subgroups of patients. Sjogren's syndrome is more often reported in older male patients without neutrophilic inflammation, whereas chronic inflammatory bowel disease often occurs in the younger patients who have neutrophilic inflammatory infiltrates in the pancreas. Patients with autoimmune pancreatitis may have autoantibodies such as anti-nuclear, anti-lactoferrin, anti-smooth muscle, and anti-carbonic anhydrase 2 antibodies. More recently, it has been observed that immunoglobulin 4 levels are commonly elevated in patients with autoimmune pancreatitis. Elevated immunoglobulin 4 levels have been used to correctly classify patients with pancreatic masses. Imaging of the pancreas by computed tomography or MRI often discloses a diffusely or segmentally enlarged pancreas with obliteration or stenosis of the main pancreatic duct. Bile duct strictures also occur when the disease affects the head of the gland. Ultrasonography may reveal a diffusely swollen hypoechoic pancreas, which has been referred to as sausage-like. The gross appearance of autoimmune pancreatitis mimics pancreatic ductal carcinoma because the inflammatory process, like the carcinoma, commonly focuses on the head of the pancreas and leads to a gray to yellowish white induration of the affected tissue with loss of its normal lobular structure. On the picture you see autoimmune pancreatitis. Pancreatic head resection specimen shows replacement of the pancreatic parenchyma by fibrous tissue, shown by the star, and stenosis, shown by the arrow, of the distal bile duct. The involved portions may be enlarged. These changes cause obstruction of the main pancreatic duct and usually also of the distal bile duct, including the papilla. In the minority of cases, the inflammatory process is concentrated in the body or tail of the pancreas. Diffuse involvement of the pancreas may also be seen, but so far it is not known how frequently and to what extent the entire pancreas is affected in autoimmune pancreatitis. In contrast to other types of chronic pancreatitis, such as alcoholic chronic pancreatitis, hereditary pancreatitis, and tropical pancreatitis, there are no pseudocysts. Calculi, intraductal calcifications, are usually absent, but if they occur, they seem to occur late in the course of the disease. The hallmark of the histological changes in the pancreas in autoimmune pancreatitis is an intense inflammatory cell infiltration around medium-sized and large intralobular ducts. Smaller ducts may also be involved, but only in advanced cases. The inflammatory infiltrate consists mainly of lymphocytes and plasma cells. On the left picture you see autoimmune pancreatitis, medium-sized duct shown by the arrow, showing typical periductal lymphoplasmacytic inflammation shown by the star, a narrowing of the lumen, but it also contains some macrophages and occasionally also neutrophilic and eosinophilic granulocytes. Immunocytochemical typing of the lymphocytes reveals that most of them are CD8 and CD4 positive T lymphocytes with fewer B lymphocytes. They infiltrate completely, encompasses the ducts, and may narrow the lumen by infolding of the epithelium, often giving the lumen a star-like structure. In later stages, the duct wall is thickened by periductal fibrosis. On the right picture, you see intensive periductal fibrosis shown by the red arrow. In a number of cases, the chronic changes in the pancreas are overlain by granulocytic epithelial lesions of the ducts. On the picture, you see destruction of the epithelium by invading granulocytes, shown by the arrow. This acute inflammatory component of autoimmune pancreatitis is characterized by focal detachment, disruption and destruction of the duct epithelium due to invading neutrophilic and occasionally also eosinophilic granulocytes, which may also cluster immediately beneath the duct epithelium. Sometimes the granulocytic infiltration extends into the small interlobular ducts and acini. Although these acute duct changes may be severe, total duct destruction, leaving scars that replace the ducts, seems to be a rare event. The extension and severity of the chronic and acute changes in autoimmune pancreatitis vary from case to case and even from one area to another within a single pancreas. In some cases, the inflammatory process occupies only a relatively small part of the pancreas and alternates abruptly with areas in which only minimal inflammation is found or the pancreatic tissue is even normal. If the tissue is only slightly affected, the inflammation focuses almost entirely on the ducts, while in severely affected pancreas, the inflammatory process involves the acinar parenchyma, in addition to the ducts, and leads to diffuse sclerosis that may contain scattered B-cell-rich small lymphoid follicles. And on the picture you see how fibrosis, shown by the arrows, replaces almost all acinar tissue and small ducts, shown by the stars. The acinar cells are then more or less replaced by inflammatory cells and fibrosis, and the lobular architecture of the pancreas is almost lost. If the fibrotic changes occupy large areas that show myofibroblasts in a storiform arrangement, they may mimic the features of an inflammatory pseudotumor. In addition to the duct changes and the sclerotic process, there are vascular changes. Most frequent is vasculitis, affecting the small veins. On the picture you see venulitis, lymphoplasmacytic infiltration in venular wall, shown by the arrows. Less common is obliterative arteritis. If the inflammatory process affects the head of the gland, as in approximately 80% of the cases, it usually also involves the distal common bile duct, where it leads to a marked thickening of the bile duct wall due to a diffuse lymphoplasmacytic infiltration combined with fibrosis. In some cases, the inflammation also extends to the hepatic ducts of the liver hilus and the gallbladder wall. The inflammatory process is usually well demarcated from the surrounding fatty tissue. The peripancreatic and peribiliary lymph nodes are enlarged and show follicular hyperplasia. The paraduodenal pancreatitis has been described under various names in the literature, which represent the different facets of this inflammation of the pancreas. Cystic dystrophy of heterotopic pancreas, periampullary duodenal wall cyst, groove pancreatitis, pancreatic hamartoma of the duodenal wall, and paraduodenal pancreatitis. Clinically, this particular pancreatic inflammation is found predominantly in male patients 40 to 50 years old with a history of alcohol abuse. The main symptoms are severe upper abdominal pain, postprandial vomiting, and nausea due to stenosis of the duodenum and weight loss. Jaundice develops in approximately 20% of the patients. Imaging may reveal cystic changes in the duodenal wall, calcifications in the paraduodenal pancreatic tissue, pseudocysts in the at the duodenal wall, a tumor in the region between the duodenum and the pancreas, and irregularity in the pancreatic ducts in the head of the pancreas. Grossly, there is either thickening and scarring of the duodenal wall, shown by red arrows, particularly in the area corresponding to the minor papilla, that extend to the adjacent pancreatic head tissue, shown by the black stars, and or sieve-like cystic changes in the duodenal walls, shown by black arrows. The cysts contain clear fluid, but others may have more granular white material and even stones. On the left picture you see paraduodenal pancreatitis, pancreatic head resection specimen showing intense scarring in the duodenal wall shown by the arrow with extension into the adjacent pancreatic tissue. Occasionally, some of the cysts may have a diameter of several centimeters. The fibrotic tissue that develops in the wall of the pancreas and also involves the groove between the wall and the pancreatic tissue may compress and indent the common bile duct. On the right picture, paraduodenal pancreatitis is shown. Pancreatic head resection specimen showing scarring of the duodenal wall and the adjacent pancreatic tissue. In addition, there is a cystic lesion shown by the yellow arrow between duodenum, shown by the red star, and pancreas, shown by the black star. Microscopically, the chronic inflammatory process resides in the duodenal submucosa, the duodenal wall, and the adjacent pancreatic tissue. Typically, there are several small foci of necrosis, shown by red arrow, surrounded by a dense proliferation of cells which show all the features of myofibroblasts and are positive for muscle markers, shown by black arrows. This change is most prominent in the area corresponding to the mucosa of the minor papilla. Between the proliferation of myofibroblasts, there may be cystic ductal elements, acinar lobules, and some islets as well as nerves. Apart from cystically dilated ducts, there are often pseudocystic lesions filled with acidophilic material, shown by the star, and lined by granulation tissue, shown by yellow arrows with foreign body giant cell reactions. Occasionally, there are also clusters of eosinophils. A common finding associated with the inflammatory changes is Brenner's gland hyperplasia, which contributes to the thickening of the duodenal mucosa. If the inflammatory process in the duodenal wall extends to the adjacent pancreas, the cellular and fibrotic reaction becomes less intense, so that the central parts of the pancreatic head are usually not involved. In obstructive chronic pancreatitis, there is a focal obstruction of the main pancreatic duct, or one of the secondary ducts that lie in the interlobular spaces, leading to ductal dilatation upstream of the stenosis, into atrophy of the acinar cells, and replacement by fibrous tissue and islet aggregation. There are various possible causes for a duct obstruction, but the most important and common cause is a cancer in the head of the pancreas, shown by the star, occluding the main pancreatic duct, shown by the arrow on the picture. This process leads to a generalized involvement of the gland with interlobular fibrosis, which in long-standing cases is increasingly accompanied by intralobular fibrosis. Other causes include interductal papillary mucinous neoplasms, some cystic and endocrine neoplasms, acquired fibrous strictures of the pancreatic ducts, ductal papillary hyperplasia narrowing the duct lumen, and finally viscous mucin blocking the duct lumen. The effects of all the listed duct obstructing mechanisms can be compared with those of duct ligation in the pancreas. In the early phase after duct ligation, the acini are transformed into small ductal tubular complexes. In the next step, the acinar cells disappear, probably due to apoptosis. These changes are associated with inflammatory and fibrotic reaction involving numerous macrophages. The macrophages are the potential source of cytokines, which stimulate fibrogenesis by fibroblasts that acquire the properties of myofibroblasts. Because the inflammatory reaction takes place in all of the interlobular and intralobular areas of the pancreatic tissue that were once drained by the occluded duct, Fibrosis develops in these regions at the same pace, producing interlobular and intralobular fibrosis in equal distribution. On the picture you see a case of obstructive chronic pancreatitis in advanced stage. Dilated lobular ducts shown by yellow arrows surrounded by remnants of acinar tissue shown by red arrows embedded in fibrosis shown by stars. Pancreatic fibrosis not associated with symptoms of chronic pancreatitis is another interesting case. A special situation of duct fibrosis is encountered in cystic fibrosis of the pancreas and in pancreatic lobular fibrosis, which is frequently observed in elderly persons. Whereas the first condition causes duct obstruction due to clogging with viscous mucin, the second condition leads to narrowing of the duct lumen by papillary hyperplasia of the duct epithelium. In cystic fibrosis, complete or almost complete inter- and intralobular fibrosis develops slowly after birth, which after many years is replaced by fatty tissue. A process that is not understood so far, but is of great interest for the resolution of fibrosis. In cystic fibrosis that is not caused by the common DF508 mutation, but results from other mutations such as R117H mutation, acute pancreatitis may develop. In elderly persons, the pancreas may contain ducts narrowed by ductal papillary hyperplasia, a lesion that has now been termed pancreatic intraepithelial neoplasia type 1b. In association with this lesion, there may be patchy lobular fibrosis in the periphery of the pancreas shown on the picture. The fibrosis affects the lobes that are drained by ducts showing pan-IN1b lesions. The extent of this lobular fibrosis varies from person to person, and the most severe form and the highest incidence, up to 50%, are found in persons older than 60 years old. The most important and common inflammatory pseudotumors are those arising in association with autoimmune lymphoplasmacytic sclerosing pancreatitis. These tumors have to be distinguished from malignant fibrous histiocytoma and true inflammatory myofibroblastic tumor. In elderly person, the pancreas may contain ducts narrowed by ductal papillary hyperplasia, shown on the picture by the arrows, a lesion that has now been termed pancreatic intraepithelial neoplasia type 1b. In association with this lesion, there may be patchy lobular fibrosis in the periphery of the pancreas, shown by the stars. The fibrosis affects the lobes that are drained by ducts, showing pan-IN1b lesions. The extent of the lobular fibrosis varies from person to person. The most severe form and the highest incidence are found in persons older than 60 years old. Cirrhosis is defined as the histological development of regenerative nodules surrounded by fibrous bands in response to chronic liver injury that leads to portal hypertension and end-stage liver disease. Recent advances in the understanding of the natural history and pathophysiology of cirrhosis and in treatment of its complications resulting in improved management, quality of life and life expectancy of cirrhotic patients. At present, liver transplantation remains the only curative option for a selected group of patients, but pharmacological therapies that can halt progression to decompensated cirrhosis or even reverse cirrhosis are currently being developed. Fibrosis describes encapsulation or replacement of injured tissue by a collagenous scar. Liver fibrosis results from the perpetuation of the normal wound healing response, resulting in an abnormal continuation of fibrogenesis, connective tissue production and deposition. Fibrosis progresses at variable rates depending on the course of liver disease, environmental and host factors. Cirrhosis is an advanced stage of liver fibrosis that is accompanied by distortion of the hepatic vasculature. It leads to shunting of the portal and arterial blood supply directly into the hepatic outflow central veins, compromising exchange between hepatic sinusoids and the adjacent liver parenchyma, hepatocytes. The hepatic sinusoids are lined by fenestrated endothelia which rest on a sheet of permeable connective tissue, the space of Disse, which contains hepatic stellate cells and some mononuclear cells. The other side of the space of Disse is lined by hepatocytes, which execute most of the known liver functions. In cirrhosis, the space of Disse is filled with scar tissue and endothelial fenestrations are lost, a process termed sinusoidal capillarization. The normal adult liver weighs 1,400 to 1,600 grams. It has a dual blood supply, with the portal vein providing 60 to 70% of hepatic blood flow and the hepatic artery supplying the remaining 30 to 40%. The portal vein and the hepatic artery enter the inferior aspect of the liver through the ileum or porta hepatis. Within the liver, the branches of the portal veins, hepatic arteries and bile ducts travel in parallel with portal tracts, shown by the arrows, ramifying variably through 10 to 12 orders of branches. The most common terminology used to describe the hepatic microarchitecture is based on the lobular model shown on the picture. This model divides the liver into lobules 1 to 2 mm in diameter that are centered on a terminal tributary of the hepatic vein and demarcated by portal tracts as their periphery. These lobules are often drawn as hexagonal structures, though in humans the shapes are far more variable. Nonetheless, it is useful simplification. A second model divides the liver into triangular acinate based on the position of hepatocytes relative to their blood supply. The hepatocytes in the vicinity of the terminal hepatic vein are called centrilobular. Those near the portal tract are periportal. Division of the lobular parenchyma into zones is an important concept because each zone differs with respect to its metabolic activities and susceptibility to certain forms of hepatic injury. Within the lobule, hepatocytes are organized into anastomizing sheets or plates extending from portal tracts to the terminal hepatic veins. Between the trabecular plates of hepatocytes are vascular sinusoids. Blood traverses the sinusoids and exits into the terminal hepatic veins through numerous orifices in the vein wall. Hepatocytes are thus bathed by well-mixed portal venous blood on one side and hepatic arterial blood on the other. The sinusoids are lined by fenestrated endothelium that overlies a perisinusoidal space, the space of Disse shown by red arrows on the picture, into which abundant hepatocyte microvilli protrude. Attached to the luminal face of the sinusoids are scattered Kupffer cells shown by green arrows, specialized long-lived tissue macrophages that arise early in embryogenesis. Another specialized cell type, the hepatic stellate cell shown by yellow arrow, is found in a space of Disse and has a role in the storage of vitamin A. Between abutting hepatocytes are bile canaliculi, channels 1 to 2 nanometers in diameter that are formed by grooves in the plasma membranes or of adjacent hepatocytes and are separated from the vascular space by tight junction. These channels drain successively into the intralobular canals of Heron, periportal bile ducts, and finally into the terminal bile ducts within the portal tracts. As noted earlier, hepatic stellate cells reside in the perisinusoidal space of this. This space separates hepatocytes, which are lined with a low-density basal membrane, from endothelial cells, which form the walls of the hepatic sinusoids. Loss of fenestration is an early event in hepatic injury and is accompanied by secretion of extracellular matrix into the space of this by hepatic stellate cells. The loss of fenestrations or capillarization of the sinusoids interferes with the critical metabolic bidirectional homeostatic flow between mixed blood from the hepatic artery and portal vein and the functional cell of the liver, the hepatocyte, and underlies the link between fibrosis and organ dysfunction. As more extracellular matrix is deposited, its components progressively infiltrate into hepatic parenchyma, first as an expansion of portal tracts with fibrotic tissue, followed by vascularized bridging septa between portal tracts, and eventually into frank cirrhosis with extensive replacement of parenchyma with bands of fibrotic tissue interspersed with characteristic regenerative nodules. This gross distortion of the hepatic parenchyma and vasculature undermines the synthetic detoxification and filtration capacity of the liver and elevates portal pressure, often leading to liver failure and death. Additionally, the resultant fibrotic microenvironment is fertile soil for malignant transformation of hepatocytes. Cirrhosis is the morphological change most often associated with chronic liver disease. It refers to the diffuse transformation of the liver into regenerative parenchymal nodules surrounded by fibrous bands. The leading causes of chronic liver failure worldwide include chronic hepatitis B, chronic hepatitis C, non-alcoholic fatty liver disease, and alcoholic liver disease. While cirrhosis is a common feature of a number of chronic liver diseases, it is not a specific entity, and it is important to recognize that not all chronic liver disease terminates in cirrhosis, and that not all cirrhosis leads to end-stage liver disease. For example, chronic biliary tract diseases often do not give rise to cirrhosis even at an end stage, whereas patients with treated autoimmune hepatitis or cured hepatitis C may have adequate liver function in the face of cirrhosis. Even in diseases that are likely to give rise to cirrhosis, such as untreated viral hepatitis, alcoholic liver disease, and metabolic diseases, the morphology and pathophysiology of cirrhosis in each may be different. Histologically, cirrhosis is characterized by vascularized fibrotic septa, shown by arrows, that link portal tracts with each other and with central veins, leading to hepatocyte islands that are surrounded by fibrotic septa and which are devoid of a central vein. Liver cirrhosis is marked by the diffuse transformation of the entire liver into regenerative parenchymal nodules, shown by arrows, surrounded by fibrous bands. The nodular nature of the process is readily evident both grossly and microscopically. The size of the nodules, the pattern of scarring, linking of portal tracts to each other versus linking of portal tracts to central veins, the degree of parenchymal loss and the frequency of vascular thrombosis, particularly of the portal vein, all vary between diseases and even in some cases between individuals with the same disease. As mentioned earlier, stem cell activation and differentiation gives rise to duct-like structures, the so-called ductal reaction. In chronic liver disease, ductal reactions increase with disease progression and are usually most prominent in cirrhosis. Ductal reactions may incite some of the scarring in chronic liver disease and therefore may have a negative effect on progressive liver disease. Regression of fibrosis and even of fully established cirrhosis may follow disease remission or cure. Scars become thinner, more densely compacted, and eventually start to fragment. As fibrous septa break apart, adjacent nodules of regenerating parenchyma coalesce into large islands. All cirrhotic livers show elements of both progression and regression, with the balance being dictated by the severity and persistence of the underlying disease. As mentioned earlier, stem cell activation and differentiation gives rise to duct-like structures, the so-called ductal reactions shown by the arrows. In chronic liver disease, ductal reactions increase with disease progression and are usually most prominent in cirrhosis. Ductal reactions may incite some of the scarring in chronic liver disease and therefore may have a negative effect on progressive liver disease. Regression of fibrosis and even of fully established cirrhosis may follow disease remission or cure. Scars become thinner, more densely compacted, and eventually start to fragment, as on the right picture. As fibrous septa break apart, adjacent nodules of regenerating parenchyma coalesce into larger islands. All cirrhotic livers show elements of both progression and regression, with the balance being dictated by the severity and persistence of the underlying disease. About 40% of individuals with cirrhosis are asymptomatic until the most advanced stages of the disease. Even at late stages, they present with non-specific clinical manifestations, such as anorexia, weight loss, weakness, and eventually signs and symptoms of liver failure discussed earlier. Jaundice and encephalopathy and coagulopathy may result from chronic liver disease, much the same as in acute liver failure. However, there are some significant additional features. Chronic severe jaundice can lead to pruritus, itching, the intensity of which may be so profound that patients scratch their skin raw and risk repeated bouts of potentially life-threatening infection. In some patients, severe pruritus is the primary indication for liver transplantation. Pruritus also is frequently seen in other disorders associated with cholestasis, suggesting that it is somehow related to the buildup of the bile salts in the body, but its precise pathogenesis is unknown. Portal hypertension is more frequent and manifests in more complex ways in chronic liver failure than in acute liver failure. Portosystemic shunts develop when blood flow is reversed from the portal to systemic circulation as shown on the picture. Those shunts are principally produced by dilation of collateral vessels. Most notably, venous bypasses develop wherever the systemic and the portal circulations share common capillary beds, the most clinically important of which are esophagus gastric varices, which appear in about 40% of individuals with advanced stage liver disease. These often cause massive, frequently fatal hematemesis, particularly when there is a compounding coagulopathy. Portal hypertension often occurs and may lead to congestive splenomegaly, which can lower the platelet count due to sequestration of these elements in the expanded red pulp. Hyperestrogenemia due to impaired estrogen metabolism in male patients with chronic liver failure can give rise to palmar erythema, a reflection of local vasodilatation and spider angiomas of the skin, as shown on the left picture. Such male hyperestrogenemia also leads to hypogonadism and gynecomastia, shown on the right picture. Hypogonadism also may occur in women with disruption of hypothalamic pituitary axis functioning. Most chronic liver diseases predispose to development of hepatocellular carcinoma. The course and severity of chronic liver disease with cirrhosis vary widely from patient to patient. Even in instances in which cirrhosis regresses following disease remission or cure, portal hypertension may persist due to the presence of irreversible shunts. The causes of death are liver failure, as in acute liver disease, and hepatocellular carcinoma. Clinical and laboratory findings are the main criteria used to gauge prognosis and disease progression. In some centers, portal venous wedge pressures are measured to assess the degree of vascular obstruction. Liver biopsy findings correlate with the presence and severity of portal hypertension. For example, specimens with thin fibrous septa and large islands of regenerated parenchyma are unlikely to be associated with portal hypertension, whereas broad bands of fibrosis and loss of parenchyma portend the development of portal hypertension and 8th-stage liver disease.